minutes. Thank you for joining us. Once again, if you folks are just joining us, welcome. We are going to start in a few minutes. We're going to give some folks an opportunity to jump on. I see we have some folks on Facebook joining us. We have folks joining us on Zoom. Shout out to everyone who has carved out some time to participate in this very important virtual event. We are practicing social distancing. We are practicing responsible information dissemination. And hey, with the use of technology, we appreciate you folks joining us from all parts of the world. We have Nani Wilson joining us. I'm going to give a couple shout outs to some folks as I'm scrolling, and forgive me if I don't mention your name, but we got my good friend Toka, who is joining us as well. Tavai obviously is here with us. So thank you guys. We're going to go ahead and have a couple more minutes to let folks work their way in. And on behalf of the organizers and everyone here at the Pacific Islander COVID-19 committee, thank you guys so much for joining us. Once again, my name is Joey Kenga. From Island Block Radio. We're going to start in just a few minutes. Thank you very much. Okay, I think we are ready to go. Welcome, good morning, good afternoon, good evening, community. Welcome to the Pacific Islander COVID-19 National Town Hall. It is my honor to be your MC for today's program. My name is Joey Kenga. I am of Chamorro descent. Hafaday, Dunkalunan Sus Masi, for carving out some time, as we said, to join this particular event. As the indigenous people of Oceania, it's our protocol to pay our respects to the land that we are on. And although we may be in different parts of the world or the country, we must acknowledge the sacrifice and the sacredness of the land that we stand and the original people that the land belongs to. On behalf of the National Pacific Islander COVID-19 response team, I pay my respects to the sacred land that I am on here in Los Angeles County, the original people, the Tongva people. So we humbly ask for your permission as we continue our dialogue to acknowledging that in this work, we recognize their presence and that of their ancestors. I also want to pay respects to our elders that are also here with us today. They are the shoulders that we stand on to do this work. We recognize that we are only able to serve in our capacities because of the sacrifices and the love that they have taught us to uphold. And so thank you very much, Dunkel Nancy Jules Masi, for teaching us. We hope that we can carry on the legacy forward in serving our communities. Today's town hall is an offering of the National Pacific Islander COVID-19 response team. Now, this response team is a national group of Native Hawaiians and Pacific Islander researchers, health experts, community leaders, and advocates formed to plan and implement an infrastructure for informing and supporting families and communities about COVID-19. Our national lead is Dr. Reynald Samoa, with technical assistance led by Dr. Nia Aitaoto. Let me just take this time to say that I am a proud Chamorro man, so forgive me if I mispronounce some of my Polynesian brothers and sisters, their names. I promise I will do my best. Now, the National Response Team is made up of regional response teams that are connecting this important work to their respective communities and regions, including teams in Arizona, Arkansas, Northern California, Southern California, the capital to include Washington, D.C., Maryland, and Virginia, Hawaii, Oregon, Utah, and Washington. We hope that you will stay on for the entire program today, which will run as follows. Following my remarks will be invocation and opening from Reverend Causa Caio, P.K. Thompson. Following that, we will hear directly from some who bring the experiences of those affected by COVID-19 in our community. You'll also hear stories from our Arkansas community, who has the highest case numbers in our community in the entire country. Perspective from a family that had multiple members infected, and experiences from the front line. You will also have a chance to ask questions following the panel. Following the panel, we will hear about the data, which tells us about the impact this is having on our community. We hope to bring you a better understanding of why our community is disproportionately affected by the coronavirus. After that, we will hear from a physician about testing, what the different tests tell us, and why one is one of the important first steps in protecting our families. Following these presentations, you'll have a chance to ask any questions that you might have. The following Q&A, we will close out with a blessing and hope that we will successfully provide you with some key information about why it is up to us to protect those that we love. If you folks are familiar and are on the Zoom, there is a Q&A icon on the bottom. Feel free to populate that with your questions, and we'll get to it as time permits. With that, we ask for your utmost respect of this space that we are sharing together. And before I ask Reverend P.K. Thompson to provide the blessing to open up our program, I'd like to introduce him, Causa Caio, P.K. Thompson, as a Samoan clergy, activist, theologian, which is secondary to his role as a husband to his wife, Mainland, and father to their 5 daughters. Reverend Thompson is the senior pastor of the Dominguez Samoan Congregational Christian Church in Compton, and currently a PhD student at the Claremont School of Theology in Claremont, California. His ministry encourages people to be change agents in the world by invoking a more socially conscious ethic of Christian practice. Thank you, Reverend P.K. Thompson. Thanks for joining us.
All right, thank you so much, Joey, for that introduction. And so I want to greet everyone that is joining us today. And I have been tasked with offering an invocation of a spiritual strengthening and encouragement in this time as we commence today with some really, really important information and exchange of dialogue. I want to start that off with from the Christian traditions, and I acknowledge that we come from different walks of life and different faith traditions. And I ask those of you who are not Christian to meditate alongside me as I go forth with this message from the Christian Bible of Psalm 131. And Psalm 131 reads, "O Lord, my heart is not lifted up. My eyes are not raised too high. I do not occupy myself with things too great and too marvelous for me. But I have calmed and quieted my soul like a weaned child with its mother. My soul is like the weaned child that is with me. O Israel, hope in the Lord from this time on and forevermore." I want to expound a little bit on what this particular psalm means. You know, when in the Hebrew tradition, when the Israelites came upon certain challenges of their journey, which was a quite long journey, they would always sing and, you know, look to the heavens for some sort of sustenance and comfort, both for physical survival, but also for spiritual survival. And I think in this time right now, as we begin to talk about the things that we have all joined together today for, I think alongside, coupled with the scientific research and the medical information that we'll receive and the doctors and the community leaders that have gathered, I think it's also appropriate that we petition some sort of spiritual strengthening in this moment as well, just to get us by as we are now moving into a different phase of what COVID looks like, but also acknowledging that there's so much more to learn. And just like the children of Israel, we don't know it all. But we look to our leaders in our communities, and especially myself as a Christian, we look to the sky and pray for some sort of guidance in such time. So before I continue on with a little bit of what I have prepared, I want to say a prayer for us this morning and move into that. God of love, God of justice, God of healing, kindness, community, God of all people, of all colors, of all creeds, of all religious traditions. We are joined today with so many different leaders, so many different perspectives that are at the table right now, seated to have discussions and join in dialogue. We're thankful for their efforts. We are thankful for the leadership that they demonstrate, but we're also thankful for our larger community who have gathered and those who will continue to listen in. We know that in this moment of COVID-19, that there is so much misinformation, that there is so much confusion and so much political leanings and affiliations that sort of draw our attention away from the real issue at hand, which is to continue life, to help people, and to make sure that everyone receives the proper care and the proper medical attention that they need, and especially the information that they long for. We ask that you bless this meeting of minds. We bless the community that has gathered. We bless those who are listening in from wherever they are right now. And we ask that all the things that we do today be for the sake of not only our people, but also the future generations, God. The younger folks, let these conversations be a bridging between those intergenerational gaps. We pray to you today, grant us wisdom and knowledge so that we may go forth with more learning, with more knowledge, with more wisdom than we came into this discussion with. And all these things I ask in the name of Jesus, amen. And so with that being said, I wanted to share something real quick. I've been asked to say a little bit of something about the world as it is right now. And one of my favorite theologians, Christian mystics, His name was Howard Thurman, who was a teacher of Martin Luther King Jr. In Boston. And Thurman once wrote, "Over and over, we must know that the real target of evil is not the destruction of the body, the reduction to rubble of cities. The real target of evil is to corrupt the spirit of man and to give his soul the contagion of inner disintegration. To drink in the beauty that is within reach, to clothe one's life with simple deeds of kindness, to keep alive sensitiveness to the movement of the Spirit of God in the quietness of the human heart and in the workings of the human mind. This is, as always, the ultimate answer to the great deception." And speaking on that right now, I am aware, just like everyone here is very conscious and aware, that we live in a very, very unsettling time in our society, not only here in these United States, but I think globally. Communities are experiencing grief and loss from this COVID-19 virus, but communities are also being ravaged right now when we talk about these United States and the issue of Black lives and Black blood lost innocently at the hands of law enforcement. And I think Thurman's quote speaks to a lot of some of the confusion, some of the rage, and what James Baldwin used to call the prophetic and righteous anger. It speaks to the great deception of where the true disease in society lay. Eventually, hopefully, with the help of medical professions and the people that we rely on, COVID-19, we'll hopefully have a vaccine one day. People will hopefully be cured and will be safe, in society, with discussions like this continuing to happen. But there's a larger disease in this country and the world when we talk about racism and white supremacy and all of those things. And I think in these United States, we are in a time of reckoning. I think what COVID-19 has done, it has unraveled some of those underlying disparities within our communities of color as well. And as a Christian, I have to pay attention to those things. As a religious leader, I'm always told which specific box I belong in. And for me, social justice and social consciousness is really part of the Christian tradition. It really is the fabric and the identity of a ministry that's centered on Jesus, who was one, an undocumented person, two, who was a victim of the state, who was executed innocently by police brutality at the hands of an empire or a government. And so those things are what call me to sort of be nurturing, and I think call us all to pay close attention to not only the health disparities within our communities and keeping our people safe and making sure that they stay informed, but I would hope as a Christian pastor that we meet at the intersections of what race looks like, of what economic justice looks like, of what food justice, looks like, about health and welfare, all of these issues and the lack of employment resources in our communities, which of course is why the US Census data that we are in right now is so important. So I hope that as we go on this journey right now and inform our communities about COVID-19 and keeping our people safe, I hope that we can look at this moment of being uncomfortable and unsettled and at least experience a little bit of what's just a fraction of what our Black brothers and sisters are experiencing right now when you see continuous violence at the hands of those who are tasked with keeping us safe, all of us safe. And my message today right now is proximity, being in closer proximity to sort of settle the noise of deception that comes to us from different places and different parts of our society. And I would hope that as we are done with these discussions, that this not be one of the last discussions, that this be one of many different discussions that can intersect with race. Then we talk about indigenous rights, that we talk about countries like West Papua New Guinea, who are also our Black brothers and sisters, who are experiencing oppression and marginalized in this very moment. And especially as we talk about trans lives in these United States, we talk about Native American lives, and that all of these things bring us to the table, and we just continue to have those conversations. And I think as a pastor, that is God's will for all of us. Thank you all. Thank
you so much, Reverend Thompson. Wow, some salient points there. Obviously, we encourage you folks to go ahead and take a piece of paper out and a pencil, jot down some notes of how you can obviously help our community. And let me take this time to please share this feed on Facebook. You guys have the technological savvy to join on the meeting in the first place. So please, we encourage you to share this on Facebook, and please hashtag Pacific Islander COVID-19. Pacific Islander COVID-19, so that people can reference this meeting it'll be more readily available to them in the future. Our Native Hawaiian and Pacific Islander communities are facing the worst infection and death rates due to COVID-19 in the states, especially the states where we have the largest population. In fact, just this past week, the state of Arkansas surpassed California with the highest Pacific Islander case numbers at 857 positive cases compared to California's 778 cases. These numbers represent lives, a brother, a sister, a mother, a father, auntie, uncle, grandparents, friends, and family. We are bringing some of those voices and stories here today. Moderating our panel are two community voices from the Polynesian community, Poly by Design's FICA podcast, none other than Carl and Naki. Ladies and gentlemen, Annette Naki Moli is the co-founder of Poly by Design and the FICA podcast. Naki is a proud mother of 5, a defeater of cancer, a vocal advocate for victims of sexual abuse. Deeply rooted in her Samoan community and culture, she strives to build positive connections to uplift her people. Mr. Carl L. Johnson is a husband, a father, son, brother, and a friend. He is the co-founder of Poly by Design and the FICA podcast. Carl is the proud father of 21-year-old triplets and a defeater of cancer himself and a believer in the life mantra, waste no minutes. Strong in his spirituality, Carl strives to build positive connections to lift his people as well. Ladies and gentlemen, my colleagues in Pacific Islander media, please bring your attention and go ahead and feel free to clap for Carl and Naki of Poly by Design. Thank you.
Thank you, Q. Thank you so much.
Thank you so much for that, Q. What an honor to be here today. You know, in these uncertain times, there are key elements that a community must possess to feel safe and act with confidence. One of the most important aspects of that is then education. Being educated as to something like COVID-19 so that informed decisions can be made must be the priority. We have a panel of Pacific Islanders here to share their information, their experiences, and their knowledge so that we as a community can become more educated and then make safe, confident decisions in regards to COVID-19.
So first we have Melissa Leyland is the founder and chief executive director of Arkansas Coalition of Marshallese, ACOM, a not-for-profit Marshallese operated organization that focuses on health, leadership, education, and culture. A native of the Marshall Islands, she became the first certified interpreter in the U.S. in 2013 and was appointed to serve on the Arkansas Minority Health Commission, making her the first Marshall Island to serve in a state agency capacity. Melissa will be sharing stories from our Arkansas Marshallese community, who are the most impacted Pacific Islander community in the country.
Pele Ili was born and raised in Long Beach, California. He currently works for ADP as a service operations manager and runs the blog The Malanga, which means the journey. His blog shares intimate stories about Pacific Islander experiences in very taboo aspects of life such as LGBTQ, racial inequalities, disease, imprisonment, and even death. In the early days of the pandemic, members of Pele's family were infected with COVID-19, and Pele documented and shared his experiences while he straddled between being a caretaker of both those who were affected and those who were healthy.
Our next panelist, Dr. Malik Fuimono, is the Associate Chief Hospitalist at Skagit Valley Hospital in Mount Vernon, Washington. He serves as core faculty of Internal Medicine Residency Program and Adjunct Clinical Professor for PNW Medical School. He is a board certified in internal medicine and has been a frontline healthcare provider since the onset of the pandemic, taking care of COVID-19 patients. Dr. Fuimono is Samoan. Melissa, we turn it over to you.
Hi, everyone. Hello, everyone. I'll start with, I think that was a great introduction. Thank you so much. Again, my name is Melissa Leilan. I will be talking to you a little bit about what's going on in the PI communities in Arkansas, particularly the Marshallese community that's been hit pretty hard with the COVID-19. I'll also give you a background of our organization. Just quick walkthrough real quick. Our vision is to have a better tomorrow. Mission is aspiring for growth through education, leadership, health, culture, and commitment to the community. Is one principle, if I say that we follow, I will have to say is kindness is life. Our ancestors have this proverb that says, Jojo Nore, which basically translates that into kindness is life. So moving on, I think there were issues prior to COVID-19 that existed, social economic status that long linger around for a while before COVID-19, but just the fact that the presence of the COVID-19 came in, it just heightened the, again, the disparities in this particular community. And I can start with the most obvious one. Many of you know Marshallese are under this Compact of Free Association, COFA. So therefore, there's this thing about not having access to the Medicaid program since the welfare reform kicked in 1995. So that's been a long lingering issue. But I think what that created, it's that if you translate that into the community where I'm at, there's sort of this mistrust in the community and causing them to be afraid and fear to seek for medical attention. So what happens is that they're afraid that they will be bombarded with all these humongous bills and doctor bills. And sometimes they feel like when they go to the hospital, they feel mistreated because, and a lot of them listen, we get feedback from the community and they tell us, we always feel like we're being mistreated because we don't have access to insurance coverage. So that's what we're seeing. In fact, many of our community members are saying, we're afraid, even if we're dying from COVID-19, we'd rather not go to the hospital because we feel like that's our deathbed. But other issues really compounded the existing issues with that. Limited language access. We've had Marshallese that have been to the hospitals and they've been given this shot and they're asking, what is this? And then later on, they found out it was something else. And they felt like there was that miscommunication there. And also that leads to other access to benefit as well, unemployment. Usually most of the time they get denied the first time. So it takes a longer process for our folks to apply for benefits. Another issue that's pretty big is the food insecurity. And a lot of that has to do with not having access to the SNAP program. Just recently, about a week ago, that the state of Arkansas opened this opportunity for many children, immigrant children, who are in the school system and who are qualified for the free and reduced program. So that had changed a little bit, but we know that's a temporary program in place. We're just afraid if we come out of this COVID-19, what happens? I think we're going to be going back to the original condition. Again, as we heard earlier, where Marshallese deaths are accounted for over 50% of death cases in the Northwest Arkansas alone. I think we're missing, we're losing people every day. It feels like every day, and it's a very sense of loss. There is a fear of losing the culture due to, less Marshallese funeral ritual that we have to be involved in, and less of that communal sense that we're losing as well. But I also want to highlight that a lot of the positives, a lot of them do have jobs. And, again, the workplaces are kind of like this hot spot for the COVID-19. So our response, there's a lot of things that are going on. I'm gonna be wrapping up pretty soon because I think my time is up. But we're looking at, we actually got funded to start up a COVID-19 response resource center, and that will be available 24/7 helpline to assist families connecting them to resources and things like that. We also have a food pantry that we have built as well just recently. And an emergency fund. And I will be asking for many of you to support us at the end of this presentation. There has been a lot of policy advocacy work. We've met with Senator Bozeman, Tom Cotton's staff, with CDC as well for data disaggregation. So hopefully CDC was paying a lot of attention to that. So we're hoping to get somewhere with that data disaggregation, as well as the health department here. Here's our fundraiser event. So we need our brothers and sisters support us. We're getting hit pretty hard, and many families are needing more and more emergency needs, help, sorry. So that's my presentation. Thank you so much for having me. Here's our information. If you need to get in touch with us, just give us a call. Thank you, appreciate it.
Okay, hello everyone. My name is Pele Ili. This is my mom, Ina Ili as well. So I think the main reason why, I believe the main reason why I'm here is because of my family situation. But before I get into that, I do want to share like the way I communicate things and on my blog and everything is it's very open, and it's very it touches on subjects that a lot of Pacific Islanders don't feel comfortable talking about. And it's a very, it's a platform for people to be humble about their experiences, which is why I knew right when this was happening to my family, I wanted to be able to document this and share it with everybody because of how important our experience was gonna be. So that's what I was able to share, and I'm really surprised at the message that it sent and the power it had on connecting me with, this organization and this panel of members that are trying to, send this message. And I know it's really important. So now getting into my family's experience, from the start, we were not taking it seriously. We weren't as cautious, and we weren't paying attention to red flags or anything, or we were just going about business as usual with our days. And the beginning of April, towards the end of March, actually, my mom was the one who, we were very worried because of her symptoms. So what happened is she was asking, our doctors, and fortunately we do have health coverage. So she was asking, doctors like, hey, I'm having, symptoms of this virus. And so they advised her not to come and get tested. They had also stated that, she might have the flu. There's no, kind of risk or anything. And you can't really diagnose something over the phone. So it's hard to tell over the phone if you have it or not. So she sat on her symptoms for a while, over 2 weeks. And then beginning of April, she finally admitted herself into the hospital, and we all found out that she had COVID. And then it led to my brother having COVID. And then it also had my dad having COVID as well. So slow and subtle symptoms were what led up to them finding out that they had COVID. And it took them to have to take themselves to the hospital to find out that this is actually what they had. So that's when everything kind of settled in for us, and it checked in, with my mind about what I needed to do for my family as the oldest. Being the oldest, especially in a Pacific Islander family, that you have to take the reins if something happens with your family, especially with your parents. So I took it upon myself to make sure that everybody else was safe in our house. My sister was elsewhere quarantining the whole time, so she made sure to stay away from the house as much as possible. We took precautions as much as we could, and we have our youngest brother who's 12, who was high risk too because he had asthma. He has underlying issues as well. So I made sure that he was away from their rooms as much as possible when I was taking care of them when they came home. So a lot of the symptoms leading up to this, it seems like it looks like the flu, and a lot of us can try to brush it off and say that they'll take care of themselves in their own home. But at the same time, the medical attention that my parents needed, and my parents have no underlying issues at all, the medical attention that they needed and were given, it's sad to say that some people's situations, they don't have this type of coverage. They don't have this type of go-to when you think about, their situations and this disease. So we were grateful enough to have them being taken care of, but at the same time, it leads you to other questions about, if my mom and dad had underlying issues, what would have happened? Like what other things could we have taken into consideration when they were going through this whole phase? So I'm going to go ahead and let my mom kind of talk about the recovery phase, but I'm really grateful to have my parents here still, and I'm going to go ahead and kind of let her talk about her recovery phase and what she's gone through. So.
Hello everyone, my name is Lena. First and foremost, I'd like to give thanks to God for having this opportunity to share amongst our Polynesian community, and I also want to thank my son for inviting me to be here to share my experience amongst a lot of our Samoan, or not only Samoan but our Polynesian community, to let them know not every phase but just on my part, my recovery part. So March 18th was the day that I started to feel symptoms, but I thought it was just flu-like symptoms. And I didn't turn myself into the emergency room until April 3rd. And that's when I knew I had COVID. And because I waited so long, I had to be put on a ventilator. And I was on the ventilator for about 4 days. And it's something that you have to go through in order for you to know, the experience of it all. I wouldn't wish it upon my worst enemy or anybody that I love. But the recovery phase was the hardest because of my breathing. Just to take a breath was so hard. Like things that, we take for granted, the small things for me was like, now that I'm recovered, I thank God just to breathe. But the recovery phase for me was the hardest. And my doctors told me, I didn't think, anything of when they were telling me like, because I had to be put on oxygen. And for about 2 weeks, but my husband was like very supportive, but at the same time, he told me, because I was so clinging on to the oxygen because I was afraid if I stopped, taking the oxygen, like I'm going to lose my breathing ability. And so he helped me to wean me off of the oxygen. And my doctors were very caring. They called us every day to check up on our oxygen levels and our blood pressure. And but I think that's the biggest part for me was the recovery part regarding breathing. So I just want to let everybody know that no matter what, our faith in God is the biggest part of recovery, especially for us Polynesians. We grew up on, God, family, and then everything else falls into place. And my faith in God is what brought me to here we are right now. And I just want to thank everybody, and for everybody out there that's trying to recover, or people that are experiencing symptoms, please don't wait as long as I did. That was my fault for waiting, because us Polynesians, we're used to, no, I can handle this, I can do this, but that was my fault. But don't wait. Take care of yourself. Your health is everything, because if you can't take care of yourself, you can't take care of your family, especially the ones that need you the most, which is our kids. So thank you, guys.
Thank you to the Ely family. Those are powerful stories when they come from people that look like us. So thank you so much. Dr. Fui Maono, we yield the time to you.
Hello, Alpha Lava. Dr. Reno Samoa asked me to share a story about being a frontline worker. Hearing the story of family members who were on the other side of this battle really, puts things into perspective. And hopefully I'll share with you guys the perspective of a healthcare worker. It's going back to the early days of the pandemic. The state of Washington, where I live right now, reported the first case of COVID-19. It was at Providence Hospital in Everett, which is like 30 minutes away from where I live. And then the first outbreak was also in the state of Washington in a nursing home in Kirkland, which is near Seattle. So we were one of the first place to get COVID. It was only a matter of time before we knew we were going to see it in our hospital. And, a team of us doctors, as well as a team in our hospital, were preparing ourselves for the worst. Knowing what was going on in China and the rest of the world, we were trying to prepare ourselves as much as possible. At the time, it was a very scary time. Being a frontline worker, my family were afraid of me going to work. I remember before I go to work, my mom will call me and ask me to be safe out there. Being a mother, it was tough for them. Every day I go to work, I would try to hug my family and kiss my kids. It kind of reminded me of the time where our military brothers and sisters say goodbye to their families, going out to war, not knowing if they're going to get back. It kind of reminded me of that, how tough it was to go out there. But it was very tough. After work, I distanced myself from my family for, as soon as I get into the house, I take my shoes off, try to shower, trying to separate from them in a guest room. So it was very hard to be connected to my family at that time as well. With the social distancing and the fear, normally the normal reaction is you gotta connect to your family, trying to hug them and tell them that everything was fine. But with the social distancing, it was very difficult to do that. I also want to share that Mount Vernon, where I work, is where the famous Skagit Valley Choir originated. it's been quoted in a lot of newspapers as well as social media. There were 60 members of a choir in the church next to my hospital. 40 of them were diagnosed with COVID-19. 3 were admitted to the hospital and 2 died. And 2 of those people who died, actually, I was the one who took care of them and admitted them. So, it was a very tough time. One of the things that that happened was they couldn't allow family members to visit their family members inside the hospital, and it created a lot of uncertainty for family members as well as us, because we usually rely on family members to bring support to the patients. I remember at meeting one of the older lady, the only reason we allowed her family was because the patient's gonna have a few hours to live. And the only time we allowed the family to come in was to say goodbye. And that was a very tough thing to see. But there are positives out of this outbreak as well. There are cases where people were sick and were able to go back home to their families. I remember there was a Spanish gentleman who was admitted for shortness of breath. We think he had an infection. He was very anxious, but when I told him his COVID-19 test was negative, he asked me to send him home so he could celebrate with his family. So those are the little victories that really push us healthcare workers to see our patients and try to, have faith and try to be with them in this tough time. I'll be lying if I say that none of the healthcare workers were afraid, because all of us were afraid. We could see it in our eyes, though, with the nurses, with all the staffing in the hospitals. What was good about that is that our patients didn't see the fear in our faces because we were wearing a mask. But deep inside, it was very tough going out there. I could probably have an analogy of going to war without a weapon or fighting an enemy that you cannot see. The weapon that we doctors and nurses use is our knowledge. We spend years studying diseases, how to diagnose, and knowing the treatment without even looking at books. Unfortunately, the enemy is a very new virus we've never seen before. Nobody actually knew how to treat it, how to keep people alive. So it's a very tough time not knowing what to do, though, because we have no weapons to fight this war. And also we had no protection. As you recall, there was a lack of PPEs, masks and gowns for healthcare workers to protect ourselves. And we feared bringing the virus back to our families, and it was a very tough time. But through it all, all of us keep going. We had no choices but to go to work because we see our work as a calling rather than a job. And that really gave me motivations to go, sharing the family that just spoke about their experience. What kept me going was my faith in God. I'm a Fafiao's son. I grew up in the church. I knew the power of prayer, and only God is the greatest doctor, and he's the one who's going to provide what we need in this pandemic. And, we usually say prayers and before I go to work every time, and our family were there to support me. So they gave me the strength. They gave me, the motivation to go work, even though, I wanted to stay with my family. I heard a quote saying that God does not put heavy burdens on weak shoulders. And despite these tough times, I think our people are strong. We've been through way more worse things. And if we have faith in God and have each other, I think we're gonna make through this. It was tough to connect to patients because we couldn't hold their hands. We tried to encourage them, but we knew in the back of our mind that researchers were very limited at the time. Right now there's a lot of good news is coming through with drugs like remdesivir, which shortens the time you're sick by 4 days. Last week there's a new study that came out that shows dexamethasone, which is a steroid, which actually improved mortality. So again, God has not forbidden us. He's giving us doctors and scientists and people in the healthcare front to bring us these tools to kind of fight this enemy. And, you know, it's not over yet. I think I need to remind everybody to continue listening to our healthcare providers. They're doing their research. They know what they're doing. Continue wearing our masks and social distancing. I like to share a quote that Joseph Seia reminded me in our task force meeting a few weeks ago. It's a Samoan proverb which says, "If a foal alamel," which translates, "the spiny starfish contains both injury and remedy." Our community has the power to heal ourselves. I think we need to kind of go back to our roots and our culture of family. We are here to support each other. And I think despite the hard times we've been through, there's a long way ahead of us, but we are strong. And I'd like to thank the panel for inviting me to share my story. Thank you.
Thank you, Dr. Fuimaono. Thank you, Pele, and your mother and your family for sharing. And thank you, Melissa. It's so important for us to see the people part of it and hear the personal stories of it. Like when Melissa says, you know, one of their sayings is "have a better tomorrow." Our people are trying to have a better tomorrow. And a piece of that is becoming educated to this. When Pele says, you know, and shares how it was for his family, and we see, I'm getting texts that are saying to hear the families talk about it and see the faces and hear those stories, it's extremely powerful. It's a big piece of how we deliver the message. And then to hear Dr. Fuimaono talk about, you know, the health worker, especially the PI healthcare worker, because we're so more susceptible to it. And I find it, you know, when they say that they are afraid, it makes me think back to that saying about the difference between a coward and a hero is they're both afraid, but the coward doesn't go, the hero still goes. So we have, you know, healthcare workers out there that we see the personal side of it. It's really touching. So thank you to the panelists. I think we are going to go to our Q&A box for questions. We got some questions from attendees. So I will turn that part over to Naki.
Oh, thank you. So let's see. One of the questions is, how have you been coping with everything you've endured in your experience? And what is the biggest lesson that you want to offer up to our community based on your experience?
I think that's open to the panel, right?
That's open to the panel, right?
I think I could touch base on that question, I guess, because my family directly dealt with it. I think the biggest lesson that we've learned, my family and I, is that we're not, you know, invincible as much as we would like to think, especially in our Pacific Islander. I think my mom touched base on it a little bit earlier about how a lot of Pacific Islander families, we like to keep things in-house. We like to internalize a lot of it to deal with it in our own home and not spread, you know, the message or spread any kind of communication about it, because it's not something that you would want to share with other people. The biggest lesson is, like, you know, we as Pacific Islanders are not, we're susceptible to things happening to us like this. So if you have questions, ask them. If you have worries or concerns, look for answers. If you don't know the answer, there's people that do. So, you know, there's resources out there that you just need to reach out, and, you know, kind of closed mouths don't get fed. And so you have to keep asking these important questions when things like this happen to your family. It's something that's really important. It comes really important to have a voice and communicate that, especially, you know, what we're seeing right now is that we're having a high rate, more than other, you know, communities out there, racial communities. And so it's important for us to have a voice. So we need to continue trying to communicate and spread that message, and make sure that you ask questions whenever you don't have answers. So that's kind of the biggest thing that we've learned.
Awesome. Thanks, Pele. We have Marina Tinitali, who's on the Facebook Live. How much coordination is happening with organized Pacific Islander groups to help ensure that islanders in the neighborhood are receiving the information about COVID-19 and the CDC info and nearby testing sites? Coordination among churches and the CDC would go a very long way to help identify islanders at high risk and with symptoms who are too anxious to seek help.
That question for anyone or?
Anyone, yeah.
Okay, I think from Arkansas, I think the community really has stepped up. As an organization, we want to make sure that we're part of every dialogue there is, every opportunity there is to fight COVID-19. We're lucky to have one of the only two medical doctors, Dr. Sheldon Rickley, who does have a weekly radio talk show, and he talks about these things. Also, we have a very good relationship with the health department, as well as there's a COVID-19 response task force that is available here in Springdale. So we have those ongoing communication with them, and we were also translating materials as well. And we keep, we have that, we post announcements and information about this COVID-19 on our Facebook, as well as other organizations. So there's a sort of this communal effort among organizations and the government as well. And so are the other folks like agencies.
Thank you, Melissa. Roxana Bautista asks, how do we work with our faith-based communities who say regularly, we won't get COVID-19 because we pray all the time?
Maybe I should answer to that question. Yeah, that's a challenge, right? I mean, people who are of faith seem to lose sight of what prayer actively looks like, right? And active prayer, not complicit prayer, right? Not a sort of a weak side of prayer, but prayer is also being agents of God. And that meaning that we listen to the people who are responsible for keeping us alive. And this is the message that I go to I am the pastor of a very traditional Congregationalist tradition that goes to Malua in Upolu, Apia, Samoa. And so this is the challenge. But I think from the beginning of this virus, that has been the task of religious leaders right now, is to really transform the dialogue that's happening around. And this is something that is very national in the United States. As we see now that there are states out there whose churches have, who did not adhere to some of these guidelines, or who are seeing recent spikes within those states and in those churches. And I think for Samoan people, it really is up to the religious leaders. It's up to the Faifeaus. I am a third, fourth generation Faifeau of the Lokaiki. And this is a challenge also that that we are all collectively dealing with. But we've got to be responsible leaders. We've got to be responsible leaders and say we are responsible for our congregants spiritually, but what does that actually look like also in trying to keep them alive physically? And for me personally, that means listening to the medical professionals, looking at the data and listening to stories as we have heard today from our own people who are, and unfortunately for us, it's not until we hear it from our own that the message doesn't really click and, really kind of hit home for us. And I really think that the stories that we're hearing today from Pele and also Dr. Fuimono are really, really important.
Thank you, Pastor. There's tons and tons of questions on Facebook Live and in our chat. So we're just going to move on a little bit, and every question will be answered in the chat. So thank you so much.
Okay, thank you, Neki. Thank you to our panelists. One of the things that the magic of technology allows us to do is ask the attendees questions and get the answers in a group all at once. So we're going to go to a live poll at this point. I'm glad I'm not the technical person, but so what will happen if it all works out is you will see a question appear for you to answer. And you'll have different possibilities or different answers. It's multiple choice. So what state has the most COVID-19 cases? This is where you're paying attention in class. Is it Arkansas that only has 3 million people? Is it California that has 40 million people? Is it Hawaii, which obviously has the highest percentage of Pacific Islanders? Or is it Washington? So go ahead and pick your answer, whichever one you think has the most COVID-19 cases. This is not per capita. This is just the total volume number, highest number of COVID-19 cases. And I'm going to continue talking because I'm not sure if it needs to formulate longer. But I think the data that a lot of what we're asking is going to be gone over in detail in the data presentation following this. So 47% of the people that answered Arkansas, 36% picked California, no one picked the Aloha State, and 17% of the respondees said Washington. And again, the data presentation will go into this, but Arkansas, with only 3 million people in a population versus California that has 40 million, Arkansas actually had the most COVID-19 cases. Naki?
Yeah, and then our next question is, which COVID-19 safety practice is the hardest for you to maintain? Social distancing, so trying to stay away from graduations and family events. B, masks, and sometimes they're hard to wear. And C, hand washing, where they're not always available, or touching my face, which is if you're wearing a mask, we're always touching our face. So let's see what everybody thinks is, or what is everybody's answer. Social distancing, we're PIs, so that's a big one for me. Especially with all the graduations going on, we have to practice social distancing. Masks.
Birthdays, funerals.
Right. Masks all the time.
I always lose mine.
Yeah, I need a new one every day. Luckily, they're disposable. And I've got a whole box. So, and there's places for you if you don't have masks. You can reach out to your local community center. There's a lot of churches that are donating, and then just ask, and we'll try to get you the information. Also, if we can ask you to share this so that everyone can get the information. So social distancing got 57%, masks 9%, washing hands 3%, and touching my face 38%. So social distancing is huge, and it's good that we're realizing that.
Thank you, Naki.
You're welcome.
Okay, so we are going to go and move to the numbers. And earlier I had talked about education being one of the key factors in a community when things are uncertain and we don't know whether we're making the best decisions. Numbers have a lot to do with making those kind of decisions. So we have our data prepared. And we are going to present that to you. I'm going to introduce our guest who is going to present that for you. Dr. Sela Panapasa is an associate research scientist at the Research Center for Group Dynamics in the Institute for Social Research at the University of Michigan. Okay, my screen was messing up. Dr. Panapasa has expertise in health disparities during middle to late life, minority health, and population level health data for racial and ethnic minorities. particularly among Native Hawaiian and Pacific Islanders. She has served on various committees, including the Census Bureau National Advisory Committee and the HHS Advisory Committee on Minority Health. Dr. Panapasa is a Pacific Islander of Roachman, Tongan, and Tuvalu descent. She is originally from Fiji. Dr. Panapasa, the virtual stage is yours.
Thank you. Can you hear me?
We can.
You can't hear me. Thank you to the organizing committee and to all of you who are tuning in to this important town hall meeting. I do know many of you from past work and interactions working in the community. And I'm delighted to share with you and be part of this important program. What I have prepared for you is a PowerPoint presentation, which I will go through. And the instructions I was given is what helped me frame this presentation. And as I go through the slides, a couple of things I would like you to think about seriously, and that is data. The COVID-19 has exposed the U.S. The U.S. position, if I may, and ability to both collect, tabulate, and report data on our Native Hawaiian Pacific Islander population. And so this presentation speaks and highlights the importance of data in accurately highlighting and presenting the needs, whether health disparities that affect our respective communities, and also the importance of data for future use, whether in the form of policy, decision-making, program development, and interventions. So what I've done is organize a story, tell a story from the global all the way down to the very specific communities that we all represent. So thank you again, and greetings to all from the beautiful state of Michigan. So let me begin by sharing, do I have everyone? Oops. Okay. Okay, can you see the screen? Can you see the screen? Oh.
Yes.
Yes.
You can see my slide. So let me begin. This slide really, I was hoping that it's an interactive slide, but unfortunately I was unable to get it to work on this platform. But the message here, if you take a look at global deaths due to various causes of death and COVID-19, the red, you see a red arrow at the bottom. On January 13th, 2020, the number of deaths due to COVID-19 was at the bottom, with only 2 reported cases. However, we spring forward and meanwhile, look, you got malaria at the very top, malnutrition, and right up here, you can see malaria and malnutrition, homicide, Parkinson's disease. But COVID-19 is right here in the bottom. And this was January 13th of 2020. Fast forward to May 24th, 2020, COVID-19 moved from the bottom and is now the leading cause of death worldwide. And this highlights the severity, the destructive impact that COVID-19 has on populations across the globe. So I can't emphasize, and I thought that this slide hopefully will really drill down and highlight the importance and why we need to pay attention to the impact of COVID-19 and take it seriously, because it does kill. It does kill rapidly. It also doesn't discriminate by age, by sex, by racial, ethnic group. It is serious. So with that said, we're moving from a global perspective and now focus in on the US experience. And we all know that in June 5th, 2020, the US exceeded the total number of deaths due to COVID-19. Overall, in the US, the total number of cases was over 1 million, almost 2 million total cases, and these are diagnoses with COVID-19. And in June 5th, we saw the total number of deaths due to COVID-19 exceeding 100,000 people. As you can see from this map of the US, it is prevalent in every state, with states like California, Texas, Florida, New Jersey, Pennsylvania, New York along the East Coast, Michigan and Illinois having some of the highest rates of both cases for COVID-19 as well as deaths. Now, the data I'm also using from this, for this presentation is derived from multiple sources, both federal, state, and state level. As you can see, what we know and has been reported in April 18th, among deaths, cumulative rates, both for deaths and by, based on hospitalization due to COVID-19 by age group. As you can see, the red line over time between March and April, it has been growing, and it's been led by older adults and the elderly, adults ages 65 and older. And the next age group lagging behind with a high rate of COVID-19 diagnoses and hospitalization, younger adults between the ages of 50 and 64, as well as adolescents and children. So again, the point here is that COVID-19 does not discriminate by age, but as you can see, the most vulnerable segment of the population for COVID-19 are the elderly and older adults. There's a pattern, there's a reason why the risk in that age category is among the highest. And I would like to introduce what we know from census data based on household structure, that our NHPI populations have the highest percent who live in family households. These are multi-generational households where you have a lot of children, older adults, and elderly living together, and therefore the need to protect and prevent and take the necessary precautions to prevent reduce the risk for contracting the virus COVID-19. And I think in the earlier panel, we got to learn directly from a PI family with multiple generations in the households without proper whether information, knowledge, and protection, you could see how it affects other members within the household. And we're not even going into any discussion of trying to imagine the size and the ability of these households to be able to contain or quarantine members and be able to maintain the social distancing, etc.
Dr. Sella?
Yes?
I'm sorry, this is Carl. This is amazing information. I think people just want to see it better. Is there any way to make the slide larger for the viewing audience? I'm getting a lot of questions about that because people are so interested in what you're presenting.
Okay, let me start. I'm sorry. Let me see. I need to, nope, I did not mean to. Okay, here we go. Share screen. Okay, is this better? Is this better, Carl?
I think if you go all the way to the top of your screen where you see insert, and then the above insert is the little icon above insert up top on the left. You see where it says home and insert? No, over to the other side, to the left.
Yes.
Yeah, and just go straight up above insert on the very top. There's a little, yeah, right there.
Perfect.
I think that should make it in presentation mode.
Okay, let's see.
You can also go to slideshow and do it from there. Go to the slideshow and resume slideshow. Go to the slideshow where it says slideshow. Go up.
Up top.
And to the left where it says slideshow. There should be go to the other side. I'm looking at where it says slideshow, right next to animations.
Right.
No, right. Go one over where it goes slideshow.
Yes. Okay.
One more over where it says slideshow. There you go. And now say from current slide. From current slide. Just hit that button.
Okay. I just.
Still not doing it.
Slideshow. Okay. Okay. Oh, I'm sorry. I didn't realize you didn't have, let me, I think what happened is I need to, sorry.
You're okay.
Census bucket. Okay, so so you do not have, am I sharing? Can you see the screen in front of you? I am sharing the screen. Let me try something.
Yes, we can see your screen.
So one of our guests is saying, you see at the up and then to the right, there's a use presenter view. Yeah, right there.
Right.
Yeah. And then go to slideshow and then from current slide.
Resume slideshow. Okay, so what are you seeing now? Can you see the slide? Oh.
Yes.
Okay. So is it in that full format? Okay, well. So can you see the slide?
Yes, we can see it.
Yes.
Okay. Okay. So this is the slide, the household structure slide I ended in. I think, so I want to move on, if I may, and share with you what we know from May 16th. Based on confirmed hospitalizations due to COVID-19, the medical conditions of those patients or intakes due to COVID-19. And these are results of medical conditions for adults and also children. And if you can see from the graph, the blue bar represent leading the medical conditions of COVID-19 adults admitted. into the hospital. And as you can see, hypertension, 58% of the adults had known diagnoses of hypertension, obesity, metabolic diseases such as diabetes, as well as cardiovascular disease were the leading causes or the leading medical conditions among patients with COVID-19. And among children, the leading causes, as you can see, were asthma as well as diabetes. And we know from the we know that NHPIs have the highest rates for chronic diseases, specifically diabetes. And here are results from the 2014 National Health Interview Survey, where when compared, and this is age-adjusted percentages of adults age 18 and older. And as you can see, when comparing data for NHPI to that of the total US population, as well as single race whites, Blacks, American Indian, Alaska Natives, and Asians, the NHPIs with single race have the highest rates, higher rates for diabetes. If we move on and take a look at, and what we know from this data, you can further disaggregate by racial, subpopulations within the NHPI groups. And here again, you see Samoans having the highest percentage of diabetes, followed by Guamanian Chamorros and Native Hawaiians and our other Pacific Islander. Fast forward, and so now we get to focus on these next few slides specific to COVID-19 deaths that is publicly available. And the slide in front of you is showing, is shared by CDC, is reporting COVID-19 deaths by race and ethnicity in the United States as of June 9th. And as you can see, they have data on non-Hispanic whites, 55,000, non-Hispanic Blacks at 23,000, non-Hispanic American Indian or Alaska Native, and non-Hispanic Asian, and then Hispanic or Latino. And Native Hawaiian and Pacific Islanders are in here somewhere under the other category. When we look at NHPI COVID-19 reported deaths, and this is based on current states that are reporting disaggregated COVID-19 results for NHPI. As you can see, California has the highest number of deaths due to COVID-19, with 20, followed by Washington State at 10, and Colorado and Georgia are lagging at 6, with Arkansas at 5, together with Illinois. I have a question mark on Hawaii. Such data is not publicly available for the state. If we move on and look, and here is a daily COVID-19 case rates per 100,000 by race and ethnicity, and I'm only able to, will be reporting on the results using data for the state of California. And as you can see, both Native Hawaiian and Pacific Islanders and Latino appear to have the highest rates of COVID-19 cases, with African American, Asian, white, multiple race, and American Indian, Alaska Natives lagging behind. Now, what I think is important, interesting, and needs to be noted here is that we know from the 2010 census that over half of the NHPI population is mixed race, is multiple race. And what California has done is report data for races alone and combine all multiple race into a separate category. So the results you're seeing is for NHPI alone at the top. Multiple race, we know, has a lot of NHPI. So it doesn't accurately and fully represent the impact and capture the full impact of COVID-19 on our respective NHPI population. If we look at the daily COVID death rates per 100,000 for California, as you can see, between May and early June, NHPI and African Americans or Blacks had the highest rates, death rates in that early period. But then into June, and then after June 3rd, we lost a third of the total number of deaths due NHPI deaths in California due to classification error. This was confirmed by the health department. That caused a huge decline. A third is a significant impact on death rates for NHPI. And as you can see, for the rest of the rest of the month of June, NHPI continues. African Americans have the highest rates, followed by Latinos and NHPI, along with Asian. COVID-19 death rates. So I have, this is another way, if we think of the cumulative case rates, the numbers of, the cumulative numbers of cases over this the period of May through June 15th, NHPIs and Latinos in California have the highest rates per 100,000 for the population. And if we look at deaths, cumulative death rates per 100,000, as you can see, African Americans are at the highest, and NHPI lag right next to them, followed by Latino, Asian, white, American Indian, and multiple race. But in both cases, the cases of looking at the rates for COVID-19 cases and the death rates for COVID-19 cases, even the NHPI is high, relatively high, but it would be high, without capturing those who are in the multiple race category. We're not going to get, that does not fully reflect and represent the impact for NHPI. So in my final few slides, as you can see, data collection and reporting remains a major barrier for NHPIs. Here's the call to action. Is to require systematic and structural changes on how we collect, tabulate, and report data on the NHPI populations at the national, state, territorial, COFA states, and local community level. So I'm going to leave you with 3 goals: to require an accurate count of the NHPI population in Census 2020. We know that the differential undercount for NHPIs in the decennial census, which happens every 10 years, has been high. Here's our opportunity to correct that undercount. And I am asking, and these are the reasons. We know that the NHPI population is a distinct racial population according to the 1997 revised OMB 15 directive. And here is our one opportunity in 10 years to correct federal and state level population statistics for the next decade. And I'm reaching out to all my NHPI cousins and families to please get every NHPI household to complete the 2020 census. The form for race, this is what differentiates us and allows us to get disaggregated information on our population, is presented on the right. And I am recommending, if you have not completed your census, to please go online ASAP and complete it. Particularly of importance is if you know you have more than 6 people living in your household on April 1st, 2020. The electronic version allows you to enter more than 6 people. So let's not wait for the paper form, but go in and file. And I do want to also add, because this is related to COVID-19 and every other cause or form of death that is occurring since April 1, because of COVID-19, the Census Bureau is extending when you can file your census. And so if you have a member of if you have not filed your census today and you have lost a member of the family since April 1st, but they were part of your household in April 1st, whether it's COVID-19 or some other illness or reason, they too count. And I'm encouraging you to please complete your census and make sure they are included. My second goal is we do need to get support and push requiring federal support for the continuation of the NHPI, NHIS to monitor the health and healthcare use of our NHPI population, as they do already for all other racial and ethnic populations, and that our ongoing support to improve the collection, tabulation, and reporting of evidence-based data on NHPI populations in the United States, in the territories, and Compact of Free Association states. And lastly, to require accurate and information on the NHPI population. Tabulating and reporting NHPI data as API is unacceptable. Tabulating and reporting NHPI data as other is also unacceptable. We need to invest in the tools and wisdom of our NHPI collective and improve data collection methods to achieve accurate data on Pacific peoples in the United States, the territories, and COFA states. And I'm going to leave you finally with this quote. We should not be defined by the smallness of our islands, but by the greatness of our oceans. We must wake up to this ancient truth and together use it to overturn all hegemonic views that aim ultimately to confine us again, physically and psychologically. It is time to create things for ourselves, to create established standards of excellence that match those of our ancestors. Thank you.
Thank you, Doctor. Thank you for that passionate and eloquent presentation of data. Thank you to all those that gathered the data and broke it down. And it's so important to have this information because there's, the media is out there and some people are saying it's a hoax. Some people are saying we're opening, phase 1, phase 2, and it's hard to get information that we know is accurate. So it's so important to have this. Great point on the 2020 census because that helps disaggregate data when we ask for it in that manner. So thank you again, Dr. Panapasa. Neki.
Next, we have Dr. Kavika Liu. He is boarded in internal medicine, pediatrics, and addiction medicine, and has been the physician advisor for 2 hospitals in the Coachella Valley since 2020. He is committed to developing metrics of health that reflect international human rights and outcomes that are meaningful to patients and their communities. He is the proud father of 2 girls, Kealani and Toanelani. Dr. Liu?
Well, I'm going to go, I think that we have the slides. Okay, great. Let's go. I'm going to try and, mahalo nui to Dr. Panapasa. I'm going to try and expedite my presentation so that we have enough time for everyone else and as well as the questions. Next, please. Okay, so these are the objectives. Everyone can read them, so we're not going to go over them. Next, please. Okay, so SARS coronavirus 2 or SARS COVID coronavirus 2. The name of the illness generated by this virus is actually COVID. The name of the virus is the SARS coronavirus 2. And as we can tell by the name, it's actually related. to the SARS-1 virus of a few years ago. It's an RNA virus. It attaches to human cells through the ACE2, and its effects are primarily through the pneumocytes, or cells inside of the lungs, as well as the cells that line the inside of blood vessels, or endothelia. Next, please. And this is just a cartoon of the virus itself. We can see that it's made of a number of different proteins, as well as a lipid membrane. Next, please. And this is just, again, a cartoon of how the virus reproduces or replicates itself. We don't have to spend a lot of time on this, but if there's any questions, can always go over this. But the important thing to do is any virus will actually hijack the machinery of the cells of the host, in this case, humans, to make more of copies of itself. Next, please. Okay, we won't go over these epidemiologic principles, other than to understand that we really want to we want to pay attention to what is a true positive and a true negative, because it doesn't matter if you have testing for everyone in the world. If the tests are unreliable, that is, they're full of true false positives and false negatives, then there's a big problem. Next, please. Okay, so there's three best tests available. That would be the PCR, polymerase chain reaction test, which is more of a diagnostic test. The serologic test, which can check for either IgM or IgG, or usually both. And then the newest test, which is the antigen test. Next, please. So PCR is actually based on the RNA from the virus. The RNA is the code which enables a virus to reproduce itself, or actually hijack other organisms to reproduce itself. The testing is most well done nasopharyngally, that is putting a swab all the way to the back of the nose to actually hit the inside of the oral cavity, or through the mouth, but really the nose is the best. And we want to pay attention to the sensitivity and the specificity. This is a pretty good test. Next, please. Okay. We do know that this is a test we use for diagnosis. That is, 50% of people remain positive about until day 22, but some people may remain positive for at least 2 months. And so repeatedly testing people is generally not productive. The more severe case, the longer we see a positive PCR test, but the infectivity itself is relatively low after 8 days. That is, after 8 days, after symptoms, it is relatively difficult for people to get infected from that person's infection. The PCR testing, we have this sensitivity from 63 to 78% and specificity of 98+%. For point of care testing, we have sensitivity of 64% or specificity of 98%. That's the Abbott test that a lot of attention was being paid to, but maybe is not really the best test. Next, please. Okay, and this is the principles of the antibody or serologic testing. That is, after someone's exposed to the virus, they will generate what's called antibodies. That is, the cells of their own body will generate proteins which can help block the further entry of the SARS coronavirus into cells of the body. Next, please. Okay, so we have antibodies to both the spike glycoprotein and the nucleocapsid phosphoprotein. That's the S and the N proteins. We have very high pharyngeal shedding of the virus in the first week. Seroconversion, that is, we see antibodies after 7 to 13 days, but that is not followed by rapid decline in the viral load, or the number of viruses actually inside of the body. This test is most effective for who has been infected by the virus, who might be immune, and who potentially is protected. This test can support the diagnosis of the COVID infection when a person presents late, 9 to 14 days after the onset of symptoms, in addition to the PCR test. And you can also establish diagnosis for people with late complications of COVID illness, such as multisystem inflammatory syndrome in children, which has been receiving quite a quite a lot of attention. And for people from Hawaii, looks much like Kawasaki disease, which we're pretty familiar with, at least in pediatrics. Next, please. We have claimed sensitivity. Again, one of the problems is that the FDA has really been rushing the approval of these tests. So the claimed sensitivity is 88.7 to 100%, and the specificity claimed is 45 to 99.5%. Next, please. Okay, so here's a little cartoon showing that we have an incubation period. That is, we could say the non-symptomatic period from -14 to 0 days. We have IgM showing up from 0 to 7 days where a person might show a fever. IgM and IgG maybe up to 30 days after 32 days. And then afterwards, we'll see IgG up to the next infection when we may again see IgM. Next, please. Antigen testing, again, is directed against the N and the S antigen. And we'll talk a little bit about the sensitivity and specificity. Next, please. Okay, this may be a very, very low sensitivity, as low as 30.2%, whereas the FDA threshold is 80%. The sensitivity is higher with higher viral loads, especially during the first week of the illness, where the sensitivity can be as high as 93.9% and specificity of 100%. Next, please. Okay, this is just showing, again, the replication of the virus. Next, please. Who should be tested and when? So the question initially was much different because the testing was much delayed. That is, the CDC sort of mismanaged the initial rollouts of the test. They had very, very restricted criteria, and we probably lost the opportunity to really flatten out the curve, as we say. We want to do three things with testing. We want to have testing itself. For people who have positive tests, we want to have contact tracing. And for people who are infected, we need isolation. Initially, we're talking about testing based on risk. That is exposure or frontline workers. And remember, this is not just healthcare workers. This is anyone who is required to keep on working. This could be anyone from people working in restaurants to people collecting the rubbish to custodians to people working in grocery stores. Many different people have been frontline workers and may have been exposed. And just as a kind of footnote, this is the whole question about how many lives or how much illness will be tolerated in order to have full reopening of the economy, or how much is one life worth. Next, so the last one is testing for planning, where just about everyone is tested. That is to try and direct resources to the people who are most at risk or most exposed to the illness. Next, please. Why should we follow precautions? First of all, as Kahu, as the Reverend said, it's because unfortunately prayer does not protect from the virus. We have a hugely inequitable impact, not based on race, but on social economics and inequities. That is, it isn't because of who African Americans are, who Latinx people are, who Pacific Islander, Native Hawaiians and Pacific Islanders are. It is because of the social economics, the inequities. It's because of policy or lack of policies. It's because of the inequitable distribution of power and resources. We know that Native Hawaiians and Pacific Islanders tend to be frontline workers. That is, it's difficult or impossible to practice social distancing and to work from home, whereas people of other ethnicities, of other socioeconomic statuses, it's much easier for them to work from home. Secondly, we know that Native Hawaiians and Pacific Islanders tend to have poor socioeconomic statuses. They're more at risk because of crowded housing, segregated housing, inadequate access to healthcare and healthy foods, multi-generational households, overrepresentation in the criminal justice system, lack of paid sick leave, and stigma and systemic inequities. Next, please. We also know that Native Hawaiians and Pacific Islanders tend to have higher risk because of activities or illnesses. That is, we have higher rates of smoking and vaping. We have higher rates of chronic lung disease, such as COPD or asthma. We have higher rates of heart conditions, severe obesity, diabetes mellitus, and chronic kidney disease. Next, please. Why tests? Well, we know because social distancing, wearing masks, quarantine, contact tracing are the best tools we have to prevent the spread of the illness until vaccines and treatments are available. And despite most of the news, it's extremely unlikely that we'll have either a vaccine or enough vaccine by the end of the year. Second, kuleana, responsibility to self, family, and community. We need to know if we pose a risk to other people. Third, who is at risk? We need to know who is at risk, who is infected, and who may have infection as protection as well as tracing infections. Next, please. And that's my presentation. Ekalamai, excuse me if I did rush. I was trying and get us back on track time-wise. And I'll be happy to take any questions either live or offline. Mahalo.
Thank you, Dr. Liu. I think that that's so powerful. Knowing things that the doctor went over is important, like incubation period, load levels, contact tracing, all that. But it all starts with testing. You don't know timelines until you test. You don't know if you had it prior unless you test, and you don't know if you're possibly infecting your family until you test. So extremely powerful information. We are running a little bit behind. We're going to ask you to put the questions into the Q&A, and we will try to get to those as we get through today. But there's just, the information is too powerful to contain in the time frame we had. So we're going to go about 10 minutes over, I believe. Dr. Liu made up a lot of time, so maybe not even that. Okay, so we're going to go to our our live poll. And I did get a question, and when a doctor says the question's wrong, it makes me think that, hey, the question may be wrong. So in the previous live poll, I had asked which state has the most COVID-19 cases, and I did not specify NHPI. So if you answered California because you were thinking overall cases, you're right. If you answered Arkansas because you were thinking API cases, then you were right. But a doctor called that out, so it made me have to look and think, and he was right. So what am I personally going to do first to help our community deal with COVID-19? This is not a right or wrong answer. It is more for, how do I help? Get tested. We just talked about that. Dr. Liu went through all of the aspects of that. B, educate my circle of influence with the information I have. We're going to share this information in the slides. There's going to be the Go Live out there really in perpetuity because it's going to be on the internet. You have that information. C, maintain social distancing standard, as Naki went over in her piece. That was the hardest piece for us as PIs when we answered that question. Or D, be an advocate 100% of the time. So if you hear bad information, don't give it a pass. There is no pass for bad information. If you hear it, correct it. Take the time, use the energy to correct it when people say things that you know not to be true after you've gone through the information that we've shared today. So again, no right or wrong answer. It's just how are we going to get involved. And, close. The top answer was be an advocate 100% of the time. Information is power. We talked about that earlier. Being educated with the right information is powerful. The second most answered was B, educate my circle of influence with the information I have. Education, right? We're educating those that we're around. Social distancing, over a third of us picked that. And then I think coming off the presentation we just had, get tested obviously is important. Naki.
Yeah. So the next question is, what can I do if I don't know how to get involved? And so there is A, contact a local Pacific Islander community-based organization. B, volunteer at your church. C, be a family champion of safe COVID practices. Or D, contact PBD or Island Block Radio on Facebook or Instagram, and we will connect you to one of our regional task force groups.
I see Joey smiling because he didn't know
I
he got thrown
know.
out there today.
I know. I know. Now you're going to get bombarded, Joey. But there's
I
a
think being
volunteer.
a family champion of safe COVID-19 practices is tough, right? Like
Yeah.
if your family's not doing it and you're the only one doing it, you may feel some kind of way about that, but maybe they need to see somebody practicing that or talking to it.
Right, right. And then we're going to ask you again, if you have questions, go ahead and put it in the question and answer or in the chat box. And then someone will help get the answer. So let's see. So the highest one was A, contact a local Pacific Islander community-based organization with 59%. And then second was D, contact PBD or Island Block Radio on Facebook or Instagram. And we will connect you with the regional task force in your area. And then be a family champion of safe COVID practices, and then volunteer at your church. So those are pretty good. I like the contact a local CBO. So there you go. And those were really good questions and good answers. So we're going to thank everyone for participating in the live poll, and we're going to give it back to Joey.
Okay. All right, folks, thank you guys so much once again. In the interest of time, we are going to push through this. There's a lot of valuable information. Thank you to all of the presenters, everybody on the panels, and thank you, folks, for tuning in. So if we can do this really quickly, I know that we still have a couple more items that we want to go over. If you can just unmute your microphone and just give our panelists and our presenters a round of applause. We'd appreciate that. Thank you so much. Okay, or we can do that as well. We're gonna take a couple questions here. I'm gonna go right to the Q&A box. This is a mess. I'll just go randomly here. This is Beverly asks, Melissa, how did your organization address? Thank you so much. How did your organization address the fears and lack of information in the Marshallese community? This is from Beverly. So we have Melissa jump on and answer that question.
Unfortunately, Melissa had to leave.
Okay, no problem. We will get that information to you. Thank you for that. Let's go to our chat box. And let's see. Okay. And this is live, ladies and gentlemen, so bear with us. We appreciate you guys. From Facebook, any way to get our PI community tested at church, voluntarily, of course. I understand that you can still infect after, but if you can find out in case you're asymptomatic, therefore you can avoid spreading the virus. Great question from Facebook. If we can have Dr. Kavika, if you can answer that for us, please.
Sure. I think that the best answer to that is really to speak to the either local, county, city, or state public health department, because that certainly is, given the disproportionate rates of infection, it's really important to have the health departments realize that if they're looking to reduce the spread of the pandemic, then it's most important to target those communities which are hardest hit. And so they have, I know here in Riverside County in California, there is free testing for anyone. It just requires an appointment, but the testing is in specific locations. I think that in places where there's large communities of, large communities or concentrations of Native Hawaiians or Pacific Islanders, it's super important to talk to your health department and ask them to set up a testing site at churches where we know that the largest number of people would feel comfortable.
Got it. Thank you, Doctor. We do have time for a couple more questions. This is for Sela or Dr. Kavika. What are your biggest worries for our community about potential second wave of infection in the fall? Maybe if we could start with Dr. Sela and then Dr. Leo, if you could answer afterwards.
Should I just go ahead?
Yeah. Let's just go.
I think one of the problems is that we're not even finished with the first wave. We're clearly seeing that in many places, especially when we look from perspectives outside the United States, people are just amazed that there's reopening with ongoing outbreaks. That is, there's been a clear association of early reopenings without meeting the kind of, honestly, sort of weak metrics that were set by the CDC. And clearly a decision to sacrifice lives in the interest of dollars. And I understand that, many people, that their livelihoods are very dependent upon the jobs that they have. But, it's so critical that this was done with the understanding that these were conditional, and unfortunately there isn't. There, even with Dr. Fauci, it doesn't seem to be any kind of, consensus that the reopening has clearly failed, and that we're seeing in places where there's either large concentrations or large communities of Pacific Islanders that they're being hit. In other places, you're seeing a doubling or more. You're seeing in Texas very, very few ICU beds and hospital beds available. That we can't even talk about the second wave until we're finished with the first. But it seems pretty clear that this is going to go on, because not only was there, the too early reopening, but that people clearly are not taking this seriously. That people think that somehow that because the reopenings are that it's back to normal, and the fact is that it is not back to normal. That people are getting ill and dying. Still at very, very high rates. And we know that right here in California, our rates have been going up. So I think that the most important thing to do is to continue to do what all the participants, all the panelists have been saying is to social distance, to wear your masks, to realize that even social distancing and masks are not 100%, that we really, really need to take care of ourselves, especially our kupuna, especially our elders, especially our people who have vulnerabilities because of their comorbidities, and to take care of ourselves as well. So get tested, know your risk, and protect yourself and other people.
Thank you, Doctor.
Can I add? Oh,
sure.
Can I offer my comment? And that is, from the data, we know that what we are finding is that the trends are still increasing. We're still in the first, sort of that first period of the impact. I'm thinking with the NHPI just ensuring, we need to invest and ensure that there are resources there to support or the increased awareness and education of the community on how to protect and prevent themselves from contracting the virus, as well as providing support around contact tracing, so that we have people on the ground who are knowledgeable and have the resources and information to be able to help support and protect the communities. I think the other thing I wanted to also add is that as we, with businesses opening and with states opening up, just reinforcing the need to protect and prevent the families and communities as we move forward. But this is not, and we can't be complacent or content thinking that, you know, we're immune to the virus.
Thank you, Doctor. We appreciate that. We have time for one more question, and we're going to reserve this last question here for Reverend Thompson before we go to closing. And so, Reverend, this question is to you, and it says, can you speak to any coordinated efforts that the faith-based organization or churches are making for COVID-19?
Yeah, I'll touch on that real briefly. There is a conglomerate of pastors that are part of the national effort of COVID-19 to sort of disseminate information and to inform our own practitioners. I, in particular, am part of a regional team task force that has been tasked with monitoring the faith-based communities right now. So in that regard, we're there on the data side of it, you know, listening in bi-weekly at this moment to the new data that comes out. And I think in talking about what does the future hold as far as monitoring, as you all know, the churches will be coming back. You know, most churches are convening once again in the sanctuaries. And so it's like a double-edged sword, you know, trying to, you know, be part of the effort to reopen here in California, in the state of California, but also there's a heavy burden of responsibility that lays on religious leaders to say that the churches are open again. And there are obviously risks to telling practitioners to come back in the sanctuaries. But for those churches that have opened, it is an opportunity also to see them face to face and advocate for all of these guidelines that we've been talking about right now with social distancing. And as a pastor myself, going into this weekend will be the first time that we convene again. I've personally set up a task force locally within the church to monitor all of those guidelines. And so there's a lot of work that's gone into protecting people going back into the sanctuaries. But of course, that's all contingent on the data. Me, myself, I'm going to monitor the data and look at what the numbers look like. And there's no telling in the near future that we can open and close again, if need be, regardless of whether or not cases are spiking inside of my own congregation. But it's also a moment for me to be more proactive and say, get out there and get tested, you know, and make sure that, you know, people are in much more proximity with the information. I mean, Facebook Live services and things like that have been great, but having them in the space and telling them to go out and get tested and showing them, and you know, church members where to go is a different story. But like I said, it's a personal responsibility on behalf of the faith-based leaders. And I would say to all of the different denominations and religious traditions to do the same, to get on board and be sort of the arms and legs of the medical practitioners, all of the research that's come out. And in this way that we can help as much as possible and do our part. But that's just some of the actual things that we're doing right now.
Thank you so much for that, Reverend Thompson. Ladies and gentlemen, we're coming quickly to the end of today's town hall meeting. Before I introduce our closing blessing, I've been allotted 5 minutes to wrap up. I'm going to take 3 minutes of that time in order to get us a little bit closer to back on schedule. So just some quick announcements. If there's any information that you would like to hear more about this or from the response team, please type it in the chat as we close out. 2, check out our social media on Facebook at Pacific Islanders COVID-19 response and Instagram at Pacific Islander COVID-19 for updated information. We do encourage you folks to please share this on Facebook and hashtag Pacific Islander COVID-19. 3, please fill out the survey that will be provided in the link. The survey will then help with our work conducted by the Southern California response team. I'd like to acknowledge and thank everybody for spending your Saturdays with us. Thank you to all the panelists, the presenters. Thank the data and communication work for planning this town hall. Thank the national response team for their continued effort to help safeguard our NHPI community. Just some really closing thoughts as I have 1.5 minutes remaining in my wrap up. I got a couple jewels. Reverend Thompson says, don't forget about our Indigenous brothers and sisters from West Papua New Guinea. Thank you for that. Look at the uncomfortable moments and empathize with our African-American brothers and sisters of what's going on right now. Melissa says, strength of the Marshallese community in Arkansas to organize amidst some of the most impacted ethnic groups in the country. Pele, thank you for your courage to being the eldest and understanding the responsibility that entails, taking care of your entire family. Dr. Fui Maono, yes, you and the frontline healthcare workers are at a war, and I appreciate you identifying your work as a calling rather than a job. Dr. Sella, call to action, everything regarding data and population, and get out there and be counted for the Census 2020. Dr. Kavika, multiple types of testing and breaking down the ways that tests affect COVID-19. And the NHPI being on the frontline workers and having poor socioeconomic status and how that impacts our community. And you know what, folks, that is it. Before we go, let me clear this off my screen. I am honored and to be a part of this. Thank you to all our presenters. Before we go, I'd like to introduce our blessing presented by Haunani Apoliona with her mele. Now, Haunani is a graduate of the University of Hawaii School of Social Work. She served 18 years statewide with the Native Hawaiian nonprofit organization named Alulike Incorporated. In 1996, Haunani was elected to the statewide and served as the trustee at large for the Office of Hawaiian Affairs from 1996 to 2016, serving as the board chairperson from 2000 to 2010. Haunani was appointed by President Clinton to serve on the United States Advisory Commission on Asian American and Pacific Islanders and the United States Census Bureau Race Ethnic Advisory Committee. Haunani presently serves as the board director for the Bank of Hawaii. Haunani is a musician, a composer, and since 1982 has performed with the Hawaiian group Olomana. Ladies and gentlemen, I present to you Haunani.
Ai, ua unmute vau. Aloha no kako. Haui vau ia hui pume o kou ki ia kakahiaka ma Honolulu nei. Aloha to all of you, and I'm very honored and pleased to have a chance to participate with all of you in this very important and very encouraging collective effort among us Pacific Islanders, Native Hawaiians, and others. I'm going to share a little bit of the translation of the term Alulike with you. I would say that Alulike was born of inspiration, having worked from 1978 with the organization Alulike, which continues today, 40 plus years later. The Mana'o in Alulike, and this song was written in 1979, as I said, speaks of working together with care for each other, and speaks also to the health and well-being of Na'uiwi aloha, all of us. And it speaks also to the values of when we work together and work cooperatively. It's really about working with a strong commitment to doing excellent work, the best work we can do, working with perspective. Some people will call it humility. I call it more of a perspective and a look at how we balance all of the challenges before us. And Kalamai, there's a dog barking, but I just wanted to have us have our little corner in a place that you can see some of the sunlight and the banana trees blowing, etc. So please pardon my barking dog. Anyway, the mele also speaks of how important it is that we as the working hands together, while we may tire, we never fade because we go on. And that as we do our work, we must look to our source of strength and work and believe in what we are doing, and also work with genuine care for each other. We listen to our source of strength. We nana kuikikumu, we listen, pay attention. We are not so quick to just bring a lot of as we say, but also to be ready to work with the hands. And in order to get done, let us work together. And so with that, I think, again, I congratulate you for participating and leading our community about us all. Continue to keep that in sight, working together, and to e aluli ke mai kako e kaleo nui. Hit it. And I'll sing along with you. Aluli ke mai kako na Mahalo anui. Great job.
Thank you, Auntie.
Aloha.
Aloha.
Thank you.
Thank you, everyone.
Technology is great. We go. Hi, Neil.
Thank you, everybody. Have a great afternoon or night or morning.
And wash your hands.
Wash your hands.
Thank you, folks. Goodbye.
Thank you, everyone.
We're gonna hang out for a little bit with this running still because Facebook is on a little bit of a delay.